the most headache for in the NICU with the sepsis. The number one enemy in the NICU, number one cause of death in the NICU is sepsis. This is why we are talking about sepsis. This is my point I'm talking about. Introduction. I will talk about early onset sepsis, late onset sepsis, presentation, investigation, diagnosis, management, and complication. Bacterial sepsis meningitis continue to be major cause of morbidity and mortality in the newborn, particularly in the very low birth weight infant. Low birth weight means very low birth weight, less than 1500 grams. Why we talk about sepsis? Because the most common diagnosis in the NICU is the suspected sepsis. هتلقى why this baby admit to NICU يقول لك respiratory stress to rule out sepsis, abnormal movement to rule out sepsis, fever to rule out sepsis, mottled skin to rule out sepsis, abnormal movement to rule out sepsis. It is the most common diagnosis in the NICU. The sign of sepsis in neonate are non-specific, هنجيها بعدين, and the inflammatory syndromes of non-infectious origin, it's look like the sepsis. يكون البيشن الكاردياك لما يحصل لنا poor perfusion looks like sepsis, يحصل له mottled skin lethargy, hypoxia, tachypnea, tachycardia looks like sepsis. Metabolic disease with metabolic acidosis looks like sepsis. But this is why the sepsis is the non-specific symptom and sign. The main problem for us is to identify if neonate at risk for early onset sepsis is based on perinatal risk factors that are neither sensitive nor specific. We'll come to this one, and it is very common, the early onset sepsis. Diagnostic tests for neonatal sepsis have a poor positive predictive value. يعني هنلقى البلود culture for the neonates to be positive in the septic sepsis, in the septic neonate, it is composed of 40 to 50 to 60% will be positive. You have a 40% is the negative culture sepsis. As a result, clinicians often treat well-appearing infant for extended period of time, even when bacterial culture are negative. فيكون الculture negative, for me, I think this patient still have sepsis, this patient is septic, you have metabolic acidosis, you have so and so, continue antibiotic. Although the blood culture came negative, you will think of blood culture negative sepsis. So this why are we treating more the patient and continue antibiotic for a long time. Will come for the problem of giving antibiotic for longer period of time. So the purpose of this presentation is to provide a practical and when possible evidence-based approach to the management of infant with suspected or proven sepsis. So the definition of early onset sepsis according to CDC is the sepsis in the first 7 days of life. خلينا من slide كلها. Neonate جاء عمره less than 7 days and less, they early onset sepsis. After 7 days, this is late onset sepsis. Okay, this according to CDC. لكن for very low birth weight اللي هم قلنا less than 1500 جرام اللي هم عندهم high risk, we consider 72 hours. So they consider 72 hours is early onset sepsis. After 72 hours is late onset. Most people practically now بيعتبروا 7 days. 7 days early onset, more than 7 days late onset. I mention it in details عشان نعرف إنه which one we can consider less than 7 days. Most the challenges for the physician regarding the sepsis is identifying units with high likelihood of sepsis and initiating antimicrobial therapy early, distinguish high-risk healthy appearing infant or infant with clinical sign who do not require treatment, when to discontinue the antibiotic once sepsis is ruled out or unlikely. So this is the main thing that we need to, yes, from the line, it is very clear, yes, sepsis is going to give antibiotic, not septic stop. Always we are having the confusion, the patient who are in critical or in gray area. The patient looks sick, culture is negative. So I will give antibiotic or not. What is the cause of these symptoms? Sorry, I stopped the voice for something urgent. What is the major risk factor for early onset sepsis? قلنا بالعربي ببساطة ال early onset sepsis is coming from the mother, related to the mother. اتكلم قبل دكتور عمر عن congenital pneumonia. So what is the risk factor to have early onset sepsis? You find all things related to the mother to have sepsis in the first 7 days of life. If you have preterm birth less than 37 weeks, prematurity in general, we consider the preterm baby are immunocompromised by definition. The neonates are immunocompromised. This is why they are at risk of having sepsis at preterm number 1. Mother with GPS. Dr. Omar mentioned about the GPS, I remember, but we'll take it here in more details, and there is a clear guidelines for the newborn delivered to mother with GPS positive, GPS negative, and none. And the mother is not screened, what I will do for the baby. If the mother have rupture membrane more than 18 hours. If the membrane rupture for 17 hours, 59 minutes is not prolonged rupture of membrane. So we are talking about prolonged rupture of membrane definition is 18 hours. So prolonged rupture of membrane more than 18 hours is the risk of early onset sepsis plus chorioamnitis. We have it. What is the definition of chorioamnitis? It will come for us later because it will increase this risk for us. Still there is ethnical causes like black people, low socioeconomic status, male sex, low upgrade score, I have risk. As we mentioned that preterm, low birth weight, complication of level delivery and immaturity, all are risk factor for early onset sepsis. In general, what is the organism that we can get it from the mother? By definition, هنقول GPS plus gram negative. I will not mention all these organism, like in this what definition, what is the risk factor? Organism, we will say group B strep اللي هو GPS plus you can see here it is gram negative. E. coli, Klebsiella, Pseudomonas, whatever organism we can get it. So this is mostly this why antibiotic had to cover this organism. Among the preterm population less than 37 weeks, the incidence of early onset sepsis is approximately 7 times, and it is higher, 3.7 per 1,000 live births. It is 20 times higher in very low birth weight. This is why we consider very low birth weight is a higher additive risk to the prematurity. I bring with preterm baby and very low birth weight infants. Why we discuss about sepsis, neonatal sepsis, and all people talk about sepsis? Because we have high mortality, high morbidity. Most common cause of admission today in ICU because of sepsis. So the fatality rate is 11 to 16%, with more than 90% of deaths occurring among the preterm population, and translate to approximately 3,300 newborn affected and more than 340 deaths annually. So the early onset sepsis, we said related to the mother. Now with the good communication with the OB-GYN, and really usually we talk about this point, the communication with the OB-GYN, they having chorioamnitis, mother having fever, mother having so and so, blah, 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 I'm going to deliver the baby. Prolonged rupture of membrane, giving antibiotic to the mother, it will help. قالها دكتور عمر قبل في presentation to give the mother antibiotic more than 4 hours before delivery. اللي هو intrapartum antibiotic prophylaxis. So with improved obstetric management and evidence-based use of intrapartum antimicrobial therapy, early onset neonatal sepsis is becoming less frequent. However, it remains one of the most common cause of neonatal morbidity and mortality in the preterm population. What is the criteria عشان أقول ده chorioamnitis؟ المرضى عندها leukocytosis. I know it's related to the OB-GYN, mainly having fever more than 38 degrees, leukocytosis more than 15,000, maternal tachycardia, fetal tachycardia, uterine tenderness, or foul smell amniotic fluid. This is when to say this is chorioamnitis. طيب, who will give or to whom I am going to give the intrapartum antibiotic prophylaxis? المرضى اللي هي الGBS positive. GBS, why we do screening at 37 to 35 to 37 weeks? Because the colonization of GBS as mentioned by Dr. Omar, in the perianal area, perineum, urinary tract, and even his nasopharyngeal, it is periodic colonization. Yani you can do swab now, it is positive, you repeat after 2 weeks negative, or swab now negative, after 3 weeks positive. So this why 35 to 37 weeks to be near to the time of delivery. So I will depend on this result. If it is positive, positive, if it is negative, negative. Another point, if I have mother GPS positive, it will be considered positive till I have a negative screen. Yani if the mother is positive 10 years back and came now to deliver, it will consider positive till it have a negative screen. Okay. The unknown mother, I will come to it, is the next. So GPS bacteria, it is more worse because it came from perineal area and colonized the urinary tract. So that one is considered heavy colonization. Unless you have a bland CS in the absence of labor at any station. Absence of labor, هقولها بالعربي البسيط, in when this baby is sitting in amniotic fluid and covered with a sac. When there is a labor and contraction, these sacs, they have holes. With the contraction, these holes will open, allow the penetration of the GPS. If the mother coming for elective CS, we will mention that the risk is considered very minimal or not there at all. But if the mother went on a labor pain, she will be colonized and consider need GPS prophylaxis because this mother went on labor. What about the mother unknown? You will consider the mother as positive. If the unknown, what we are doing and treating, you go to American Academy of Pediatrics, what is the guidelines? Unknown, you do again, monitor the baby, CBC, CRP, blood culture, and observe for the baby. If the mother receives treatment, I will just observe the baby for any sign of symptoms of sepsis. If the mother even GPS received treatment. If not, unknown or not received treatment, so we'll do CBC, CRP, blood culture. Again, this is the time when women who have unknown GPS status and one of the following, we consider it same like GPS positive and she will receive the antibiotic. What happened when we receive antibiotic? We have the early onset, this line is early onset sepsis and dotted one is the late onset sepsis. So we will see there is a dramatic drop of the early onset sepsis from 1.8, 1.7 to less than around 0.3%, but there is no effect on the late onset sepsis. Some people, they will say, and some hospitals stop screening, they said, okay, the incidence is very less, 1.7, why are you going to screen? Because GPS can cause death. And when there is something related to death, you will be very aggressive in the treatment and the management. This is why they will do screening and giving treatment and decrease the incidence of GPS infection. And there is very guideline from the American Academy of Pediatrics, the last one in 2002. Prevention of early onset sepsis, as we mentioned, giving antibiotic, and we have to a lot of options of antibiotic there. If the mother having penicillin number 1, ampicillin, cefazolin. If she have allergy to penicillins, you can give vancomycin, you can give erythromycin, and the OB/GYN are following these guidelines, and to tell this mother is treated if she receive antibiotic even 1 dose more than 4 hours before delivery. Some people, therefore, 2 doses, no. 1 dose 4 hours before delivery can give protection to the baby. Prevention of early onset sepsis, as we mentioned, the giving the antibiotic to the mother is the number 1. Of course, hand hygiene, it will play a role in all infection prevention all over. For the early onset, late onset, corona, giving a good education for people about hand hygiene and hand wash. So again, this is what indication to the early intrapartum antibiotic, as we mentioned, preterm GPS, unknown GPS with the temperature or any risk factor with the mother, rupture membrane more than 18 hours, chorioamnitis. What is the late onset sepsis? We said late onset sepsis after 7 days of life. Why we have late onset sepsis? What is the risk factor? I hope you can answer me, and I want the interactive session more than staying and talking more all of the time. Okay, the incidence of late onset sepsis increase in parallel with the improvement survival of premature infant. Now, as a neonatologist, our care improve, the NICU improve, so we have a lot of babies who are preterm and they stay longer in ICU, and the care improve, the outcome improve. Staying in the hospital, giving them a risk of a lot of complication, ROP, handicap for any reason, hearing loss, vision, diaplegia, a lot of complication, and including having central line for a long time, having intubated for a long time, all these having a lot of devices in the body as a foreign body, all this is a risk factor to have infection. So stay in the hospital for a long time is a major risk of the late onset sepsis. So the risk factor, again, immaturity or preterm who are stay longer in the NICU, long-term use of invasive intervention such as mechanical ventilation and intravascular catheterization. So patient need TPN for a long time. They have central line. In mechanical ventilation now, as mentioned by Dr. Omar, that we are going more with non-invasive than intubation and invasive ventilation. The failure of early enteral feeding with breast milk, a prolonged duration of parental nutrition, prolonged hospitalization, any requirement of surgery or an underlying respiratory and cardiovascular problem. So all these stay in the hospital, giving us increased incidence of late onset sepsis, and the incidence increase with the or decrease with the increased maturation. So it is higher in the preterm, almost 35%, and it will come to 16% in the term infant. What is the most common organism? As we mentioned there, we said gram-negative. Here, because of skin devices, we have mainly it is gram-positive. All organisms can be there, but we find all this long line. This is a coagulase negative stuff. So hatidial counts is the most common cause of infection. But all other organisms can be there, especially with the prolonged use of antibiotic, stay longer in the NICU, as we mentioned, different organisms, different antibiotic, a lot of courses of antibiotic, use of a strong or big gun of antibiotic, meropenem, vancomycin, giving chance to candida and other organisms to grow. So stay longer in the unit, use strong gun of antibiotic, it will give risk of another organism, but mainly we have the coagulase negative stuff. So how the neonatal present? As I mentioned that it is non-specific for late onset or early onset. So from head to toe, any abnormal presentation of the baby or any abnormal behavior of the baby, number one is the sepsis. So abnormal movement, lethargy, tachycardia, bradycardia, hypotension, metabolic acidosis, hyperthermia, hypothermia, mottled skin, lethargy, poor feeding, vomiting, regurgitation. Sometimes the nurse tell you that I'm not happy about this baby. Really, I didn't write all this because I will stay writing till tomorrow. If the nurse stay with the baby 12 hours and she mentioned, okay, I take care of this baby yesterday, today I'm not happy about this baby, I will think of sepsis. I have one patient who have only tachycardia. Baby is very active, doing fine, only tachycardia. Is it sepsis or because of caffeine? So we did septic screen and it came out as E. coli. And one patient having only tachycardia, the doctor is about, no, baby is doing fine, it's not look septic, don't start antibiotic. So again, did septic screen, okay, let us do septic CBC, blood culture, CRP, but not start antibiotic, and the baby deteriorate within 6 hours. Again, the message for me, even I will come for that later on, when you think of sepsis, don't delay the antibiotic. So what is the diagnostic test? I mentioned it all here together, but in brief, I'm going to tell which one for early onset sepsis and which one for late onset sepsis. So number one, and the gold standard diagnosis for sepsis is blood cultures. Although, as I mentioned, that sensitivity for bacteremia is 90%, but why the blood culture we can get it negative? Because we are taking only 1 ml is for the blood culture. and this amount may be not enough to detect the organism or the bacteria. So taking a small amount of blood, time of taking the blood, maybe this is not the time of the replication of the organism, so this is why it will come negative for you. On another hand, that the baby looks well and you have a contaminated tube or contamination during extraction and you have a positive blood culture for a healthy baby. So we will have all these problems. But whenever you have a positive blood culture, don't ignore it. Yes, it came for me, start blood culture and think of contamination, repeat it. Keep the patient on antibiotic, repeat the culture. When it's negative, okay, it confirmed for me this is a contaminated blood culture. Okay, you can take blood from the umbilicus, artery, vein, but anyone can be for the blood cultures. For early onset sepsis, we'll do CBC, blood culture, and acute phase reactant, CRB, or now we are using procalcitonin. There is a lot of acute phase reactant, but mainly CRB and blood culture. In the early onset sepsis, this is the only test needed for the culture, plus or minus LB. We'll come to that one. Culture of superficial body site, tracheal aspirate, gastric aspirate, urine are of no value in the diagnosis of early onset sepsis. Please, no need for all this. No urine culture. Urine at that time will be sterile for the first 7 days of life. So it will not be helpful. Lumbar puncture, we said plus or minus. Meningitis is extremely low in the high risk healthy appearing infant and also in the early onset sepsis. Sometimes you have a patient having fever. Is it from the mother, from the baby? You need to do the LB. Blood culture alone cannot be used to decide who need a lumbar puncture. Unless you have a positive blood culture, I will do LB. It can be negative in up to 30% of infants with meningitis. Lumbar puncture should be performed in any infant with a positive blood culture. I will do. Infant whose clinical course or laboratory data strongly suggests bacterial sepsis. Again, even if you have no fever, if you have only frequent bradycardia desaturations, lethargy, mottled skin, patient sick, I will do lumbar puncture. But sometimes if the patient, for any infant who is critically ill, sometimes it's difficult for me to do lumbar puncture when the patient is very sick. He needs high frequency, imotropes, lines, blah, blah, blah. And it is difficult for me to do LB, but it is recommended. Even I will document in the system, patient need LB, but it's difficult because the patient is very, very sick, but indicated. Infant who initially worsen with antimicrobial therapy. I think of sepsis, giving antibiotic, but the patient is not improving, getting worse. I will do lumbar puncture with another screening. This patient with fever, in general, prefer to do lumbar puncture. Again, WBC, absolute neutrophil count, platelet, all this will give you a clue if the patient having help on the clue, but is not the diagnostic. Count obtained 6 to 12 hours after birth are more likely to be abnormal than are count obtained at birth. Usually, if you take any investigation at birth, it would reflect for you the maternal investigations. Okay, acute phase reactant, as we mentioned, the CRB commonly, the PENS and procalcitonin is very, very sensitive, but the main problem is very expensive, really. This is why, and as mentioned, that the CRB will not depend on one reading. You have to see the trend, and the CRB usually used as a helper in the diagnosis of sepsis, and again can guide the physician when to stop the antibiotic. When you see, okay, his CRB is 20, start antibiotic, now 7 days, the CRB is 2 or 1.5 according to the unit you use. So that one is helping in the starting antibiotic, in the guideline and help, and to stop the antibiotic. But it's not a clue or a diagnostic for the sepsis. Procalcitonin, it is not the trend more than the reading itself. This is why the procalcitonin is sensitive. As I mentioned, it is sensitive. There is a lot of other organisms for proposed as a biomarker for sepsis. So this our clinical challenge is always that most infected infants exhibit abnormal sign in the first 24 hours. 1% will appear healthy, then develop sign after a variable time. This is what I mentioned now. The patient have tachycardia only, and after 6 hours deteriorate. This is why when you think of sepsis and you took septic screen, you start antibiotic. Because in the other way, why you did blood culture? Because I think of sepsis. You think of sepsis, you have to start antibiotic. Really, it is clear. No, okay, no, take culture, stop, don't start antibiotic. Really, all or none. Either to do everything, septic screen, start antibiotic, or you think no need, or the baby healthy, no need to do the septic screen or start antibiotic. Any newborn infant with clinical sign of sepsis, even when there are no obvious risk factor for sepsis, should have an immediate food diagnostic evaluation followed by the initiation of empirical antibiotic therapy. It is clear. Okay. The treatment is different from early onset sepsis and late onset sepsis because of the suspected organism. As we mentioned, early onset sepsis, you have organisms coming from the mother, and we think of GPS. This is why ampicillin and aminoglycoside like gentamicin or amikacin. Again, if you go to increase your weapons, cefotaxime, later on, vancomycin, meropenem will be the last thing to give. And again, the duration depends on the where is the focus or what is the reason. So bacteremia without focus treat for 10 days, meningitis minimum 14 days, gram-negative meningitis we need 21 days, or 14 days from negative culture. This is why usually find the plan of physician 10 days from negative culture, 14 days from negative culture, 7 days from negative culture, depend on the site. For example, if I have osteomyelitis or endocarditis, that means I will osteomyelitis usually minimum of 8 weeks. Again, the same like endocarditis. Okay. The most important prevention of late onset sepsis is hand hygiene. Hand hygiene. For us going to an ICU, please. This is why here you wash your hands for the family visitors, wearing yellow gown, don't touch anything, sanitizer all the time. If you, we are, as mentioned for my staff, we are human being. I need to scratch my head, my nose, my ear, whatever, but please use the hand gel. You touch your phone, again use hand gel. The nurse is having papers, they read from that paper. So when they saw the baby doing something, because they do hand sanitizer before, then she hold the paper. When baby needs something, she put the paper and go into the paper. No, even what I'm telling them, open the incubator first, then use a sanitizer and then push your hand inside. Because if you use sanitizer, you are going to touch the incubator. So when you did hand sanitizer for your hands, the first thing to touch is the baby. Don't touch the monitor, don't touch the ventilator or your mobile or any paper. So the number one is prevention for all infection, especially late onset sepsis, early onset sepsis, whatever, is hand hygiene. And as I mentioned before, that the neonates are immune compromised. So please, hand hygiene, hand hygiene, hand hygiene is the number one prevention for infection. I know in our hospitals a lot of things there، المويه قطعت وكهرباء قطعت وصابون ما في واليوم ما جابوا الهاند جل، لكن معليش انا شفت حاجات كثيره. تلقى الناس داخلين بالكوت بالشنط حقتهم لابسين ساعات وختم والدبل والغويشات. For all this it had to be out. انت شغال NICU او خاش NICU، yellow gown, wash your hand, remove all accessories you have in your hands, ساعة ولا غيره, put it in your pocket. So all these are source infection. And now even people not wearing the necktie. They mentioned that we are not washing our necktie for a long time. سنة سنتين تقعد معك ربطة العنق وانت ما بتكون غسلتها. also they prevent to use it in the NICU. usually تلبس كم قصير سكراب أو قميص كم قصير بيكون preferred. For the female we can accept, but they have to wear yellow gown. So the prevention for the infection, I think is more than the treatment. When you have infection, you will not clear, it will spread in the unit, spread everywhere, so you cannot control after that. تغسل الأرضية وغسل ما عارف إيه وخذ سواب من الموية وخذ سواب من الأرض وخذ، فبتلقى الدنيا we cannot control after that. So hand hygiene please, prevention. Communicate with the OB/GYN that will decrease the early onset sepsis. Hand hygiene and our infection control parameters and measures will prevent the late onset sepsis. Why we are very worried about late onset sepsis? We said this one is we need to cover the gram-positive mainly. This is why you find the cloxacillin, vancomycin will be included in your regimen of antibiotics. Duration of treatment is another important factor to consider in empirical antibiotic therapy. So I suspect sepsis, did septic screen, blood culture, CRP, start antibiotic. 48 to 72 hours, I have culture negative, stop the antibiotic, please. Sometimes this baby change because of any reason, hypothermic, he have any other problem, his CRB going high. A lot of people said continue antibiotic, CRB is high. CRB could be high for any other reason other than infection. Pain can increase the CRB, stress can increase CRB. Staying in the NICU is the cause of stress for the neonates. This is why we continue antibiotic for longer time for non-specific reason. This is why usually I'm telling we are over in the treating neonates with antibiotic. No antibiotic is without risk. So every time we provide prolonged antibiotic to one infant, we expose every infant in the NICU to a small increased risk of resistant infection. So we have increased risk of resistance, increased risk of another organism like Candida and other invasive bacteria. يعني تصير لك organism عمرك ما سمعت بها. And the number 3, there is a strong association with necrotizing enterocolitis. So a prolonged antibiotic therapy for culture negative sepsis in preterm infant, it is time to stop, please. So prolonged antibiotic therapy is more related to institutional decision than severity of illness. Antibiotic therapy affect gastrointestinal flora of preterm infant, which can impact the elimination of commensal flora, allow for colonization by multi-drug resistant organisms and fungi, which can lead to invasive candidiasis, development of enterocolitis, late onset sepsis, and all can lead to death. Duration of antimicrobial therapy in infant with negative blood culture is controversy, وهذا اللي بيحصل مع كل الناس إنه stop not to stop, give 5 days, 7 days, 3 days. I will depend on the clinical assessment, evaluation, and my result of my investigation. If the baby is healthy, looks fine, active, feeding well, no need for respiratory support, my culture is negative, I will stop the antibiotic. So 48 hours in term healthy appearing with no evidence of bacterial infection is 48 to 72 hours is enough. Recent data suggests an association between prolonged empirical treatment of preterm infant more than 5 days with broad spectrum antibiotic and high risk of late onset necrotizing enterocolitis and mortality. So here, if you see the prolonged use of antibiotic with NEC alone, p-value is less, not significant. Late onset sepsis alone, not significant, but combined result NEC, late onset sepsis, and this is very, very significant. So please try to minimize the duration of antibiotic. Use, don't go with a strong gun or big gun from the beginning, Mirobin Vanco, and you have the resistance after that. And this is a graph showing the days on antibiotic and the incidence of NEC, which is going significantly increase incidence of NEC. So data supports short course term use of antibiotic. Theory supports short term use of antibiotic. Cost and iatrogenic harm support short term use of antibiotics. So we don't have any explanation or excuse to prolong the course of antibiotic. So in conclusion, neonatal sepsis is a major cause of morbidity and mortality. Diagnostic tests for clear onset sepsis other than blood CSF culture are useful for identifying infant with a low probability of sepsis, but not at identifying infants like to be infected. When 1 ml of blood drawn before initiation of antimicrobial therapy is needed to adequately detect bacteremia if blood culture bottle is used. And another point, now I'm in the duty, and we have don't delay the antibiotic for any reason. I have a patient who have VB shunt, just now came to ER sick, and we lethargic, shocked, and we want to start antibiotic. He have VB shunt. I called the neurosurgeon to draw from the reservoir. He said, I will come after 2 hours. I'm far from you. I said, okay, don't delay, give the antibiotic. The picture of the CSF will not change a lot with 1 dose of antibiotic. Cultures of superficial body site, gastric aspirate, urine culture, tracheal aspirate of no value in early onset sepsis, in no value in the first 7 days of life, please. LB, we said there is controversy when to do it or not to do it. We have criteria when we need to do LB for the patient. Sign of sepsis, not improve, positive blood culture, patient with bacteremia and sick neonate, putting the clinical condition of the patient in your mind. Optimal treatment of infant with suspected sepsis depend on the site, as we mentioned, with the broad spectrum antibiotic. It is gram-negative, gram-positive, meningitis, osteomyelitis. Depend on the site. We have the duration of antibiotic, and very important for you is to include the infection control or infectious disease doctor with you. دائما الاي دي لازم يكون involved معانا عشان نعرف الديوريشن الموديفيكيشن اوف انتيبيوتيك. هل انت you need to downgrade or upgrade your antibiotic. يعني حتى لو start meropenem vancomycin for a patient, I did blood culture وجاتني pseudomonas sensitive to ceftazidime, okay, stop meropenem, shift it to ceftazidime. Don't go حتى لو sensitive للmeropenem. I will keep it for something else. Okay, جيت كلابسيلا sensitive to gentamicin مثلا, I will use gentamicin and stop the vancomycin. So please, if you have a sensitivity blood culture, downgrade or adjust the antibiotic according to your result. زي ما قلنا antibiotic for 48 hours if the patient is culture negative and the baby is healthy and looks well. Again, cooperation with local microbiology and infection control staff to regularly monitoring the adequacy of antibiotic regimen, because the pattern of causative pathogens and antibiotic resistant profile may change over time and vary geographically. Change over time because we use antibiotic for a long time, we use big guns. فلو الآن كان عندي مثلا ستاف أوريوس وكان عندي كليبسيلا مع الانتيبيوتيك، بعد شويه حتجيني سودوموناس وانتيروكوكس، فتلقى الانتيبيوتيك يوز حتغير لك what antibiotic, what organism you have in your unit, and what antibiotic you have to use. This is why we have to communicate with the ID. The pathogene pattern of neonatal late onset sepsis change with time and over regions, and should be regularly re-evaluated to guide the management of late onset sepsis. Despite all effort, an early and accurate diagnostic tool for neonatal late onset sepsis is yet to be found. Given the increased resistance rate of pathogens and relatively slow development of novel antimicrobial agents, antibiotic stewardship program is designed and implemented to optimize antibiotic therapy. أي مستشفى لازم يكون عنده stewardship program يكون مسؤول منه الاي دي دكتور ويكون معه clinical pharmacist to control the use of antibiotic. يعني الليلة أحمد ده أي عيان يجيه ميروبينم فانكومايسين، لا، يكون الصيدلية ما تديك الانتيبيوتيك. What is the ID questioning will have approval from the ID. يعني when you use antibiotic for any patient, you have to have approval from the ID. You review the patient, we see the cultures. If really need meropenem, it will be dispensed to the patient and will be received. Otherwise, it will be stopped from the pharmacy. I know it is, I hope that we will reach to this point that we have a control, we have a stewardship program. أتمنى يكون الصيدليات ما تصرف أنتيبيوتيك لأي حد إنه يمشي الصيدلية وياخذ أنتيبيوتيك، والله ولدي عنده لوز ويدوه أنتيبيوتيك، ولدي عنده حمى ويدوه أنتيبيوتيك، ممكن تكون فيرال انفكشنز. فده اللي بخلي إنه الأنتيبيوتيك عندنا بقت زي الموية وما شغالة في أي بكتيريا. In the current empirical antibiotic regimen as should be implemented to avoid unnecessary use of broad-spectrum antibiotic and longer than needed duration of treatment. Up to now, the prevention is our aim. Besides strict adherence to infection control protocol and less invasive intervention unit, intensive care unit, as we mentioned that now we try to extubate the patient as early as possible if intubated. Our aim only first is non-invasive ventilation, and if intubated حتلقاه يوم يومين and then extubated عشان نقلل ventilator associated pneumonia, نقلل that there is a foreign body with secretions, need suction, نحن ندخل له organism inside, start feeding early عشان نقلل البرولونج يوز اوف تي بي ان. فكل هذه بتقلل لنا الانفكشن. And this is a reference. Thank you. I will open the question if it is there. Okay. الصوت ما واضح كان؟
واضح الصوت يا دكتور أحمد، واضح.
طيب تمام. I'm ready for أي سؤال. طيب, how beneficial is using the sepsis risk calculator in management of sepsis? Yes, I hear about it. I didn't use it for a long time, but I think it is a calculator. It is in the computer. I think it is beneficial to have your evaluation, your assessment of the patient, what is the risk factor that he have, and accordingly I will decide this patient looks septic or no, antibiotic or no, what you need to do. I think the evaluation assessment is more important than the calculator. For how long time we said prolonged antibiotic, as I mentioned that it is 48, 72 hours. This is antibiotic use till you have the get result of the initial blood culture, you have the preliminary result and final result at 5 days. So more than 5 days, if I use it more than that, why? And it is considered prolonged. Concerning blood culture, is there any difference between venous or arterial blood for taking the sample? There is no much difference because usually when you have a preterm baby and the first blood culture, you take it from the arterial. The main thing we are afraid of contamination. The main thing that the cleaning the area you are going to extract from. Umbilical catheter, venous catheter, but very rare that if you have a healthy baby to go to peripheral arterial line to get blood culture. Usually the practice that we get from the peripheral venous catheter. عايز امشي تحت للأسئلة زيادة. طيب. When to start antifungal? When I have a prolonged use of antibiotic, when I see that the patient is not improving, when I have a clue that this patient having query fungal infection. And the other thing that when we have extreme preterm in the NICU, less than 1,000, we are using fluconazole prophylaxis, and there is study supporting that. If I use antibiotic, and usually for the fungal infection, when you see that the patient is not improving well, the patient have a skin rash maybe due to fungal or is it viral or bacterial. So this is why I'm talking about evaluation and assessment of your patient. If I have a patient who have central line and have antibiotic for more than 7 days, 10 days, I will add antifungal treatment. I will usually, whenever you are going to change antibiotic, add another antibiotic, please take another blood culture. So to see, it will guide you in your management where you are going. For adding any antibiotic, starting a new antibiotic, change antibiotic, take another blood culture. Usually the practice that I have both blood culture, I start the patient, for example, cefotaxime, vancomycin, then 48 hours, I have a negative blood, I will take another blood culture. If it is negative, it will guide me for how long I'm going to use the antibiotic. Can I use one antibiotic according to culture and sensitivity, or better to use two? Initially, when I don't know what is the organism, what is going on, I will use the broad spectrum antibiotic. So I have to cover gram positive, gram negative. Then when I have the culture, I mentioned that we have to taper or downgrade or upgrade antibiotic according to sensitivity. What about swab culture of assessment of neonate with sepsis or for babies transferred to another hospital? Usually we are going to do the MRSA swab from the groin, nostril, and axilla. So a swab will be taken for the late onset sepsis or patient transferred from other hospital or coming from outside. You will do MRSA screening for the skin. We mentioned early onset sepsis, we don't have skin, we don't have gastric aspirate, we don't have tracheal aspirate, we don't have urine culture. Late onset sepsis, yes. Concerning follow-up the baby, what are the preferred investigations? If I have a patient with sepsis and I treat him blood culture, bloodstream infection, BSI, you have actually for sepsis that it is not the CLABSI, اللي هي central line associated bloodstream infection. You have bloodstream infection, you have ventilator associated pneumonia, اللي هي ventilator associated VAP. All these are related to late onset sepsis. Follow-up, the only one who need follow-up if I have meningitis. That when I need to do hearing screen, I do MRI brain if I have meningitis. But if you have bloodstream infection and I give appropriate time of management, I don't think you need to follow up the patient with another investigation or another blood culture. CRB is not specific for monitoring response to antibiotic. Any more precise tool that we can use in addition to clinical progression? This is why I mentioned we don't need the CRB only when reading. Usually we follow the trend up and down. It can give you clue. We said it is not specific. It will give you clue. Usually I'm looking for a negative blood culture. This is which will guide my treatment, my duration of antibiotic. I usually take blood culture till I have a negative blood culture, and then according to that I will adjust my antibiotic. For giving antibiotic before 4 hours from delivery, if I'm not wrong. For all mothers, even she have no symptoms, this rate will be guided, but I don't think all mothers will be receive antibiotic like a prophylactic antibiotic if she have nothing. Normal pregnancy, low risk pregnancy, coming now rupture membranes and delivered after 2 or 3 hours, I don't think they will give antibiotic unless you have prolonged rupture membrane or if the mother having symptoms. What you have given us today, we are very grateful. I just want to ask if the mother diagnosed with UTI prenatally and not treated for any reason, plus prolonged rupture of membrane less than 18 hours, but the baby is term and doing well, should we just observe or start him on antibiotic plus septic screen. If the baby is well, I will not do any septic screen or antibiotic. Usually, I will observe the baby for 48 hours. If I have no symptoms, I don't need to start him on any antibiotic or do anything. If during this time, actually 48 hours is the time the mother after delivery stay in the hospital. تقعد يوم يومين في المستشفى بعد الولادة. I will observe the baby 48 hours. If I have no symptoms, I will not do anything. If he develop symptom, I will do septic screen and start him on antibiotic. I think this is a last question I answer. We have then few MCQs we are going to discuss.